It gives me great pleasure to introduce Dr. Neil Cassell, who this year is our conference keynote speaker. Despite being blind in one eye and not completing his undergraduate degree, Dr. Cassell's unwavering commitment to making a significant impact on the world propelled him to become a leading neurosurgeon and a pioneer for focused ultrasound therapy. From a young age, Dr. Cassell was drawn to neurosurgery, gaining experience already in a neurosurgery research lab at the age of 16. He received both his undergraduate and medical education at the University of Pennsylvania and completed his MD in 1972. This is before I know many of you were born. After an internship and 2 years of neurology and neurosurgery residency in Philadelphia, Dr. Cassell completed his neurosurgical training with Dr. Charles Drake at the University of Western Ontario. And to hear more about his unique early years, I encourage you to listen to a podcast that's available on the Focused Ultrasound Foundation's website that features an in-depth interview with him. After training, he was a professor of neurosurgery at the University of Iowa and then at the University of Virginia from 1984 to 2016. He was co-chairman of the department until 2006, at which point he founded the Focused Ultrasound Foundation. Dr. Cassell will not remember this, but around 2004, he was one of the very first clinicians to order patient brochures from a new patient advocacy group, the Angioma Alliance, which was us, our first name. And for that, he'll always have a warm spot in my heart. But there's more. In April 2016, Dr. Cassell was appointed by Vice President Joe Biden to the National Cancer Institute's Blue Ribbon Panel for Cancer Moonshot Initiative. He has served on numerous standing and ad hoc committees of the National Institutes of Health, as well as in an editorial capacity for various academic journals. He's contributed more than 500 publications and book chapters to the literature. He is also a serial founder. He started Interacts, the Virginia Neurological Institute, Multimedia Medical Systems, the Neuroclinical Trial Center, the NeuroVenture Fund, MedicalSpecialist.net, and of course, the Focused Ultrasound Foundation. He has also served on several public and private sector boards. Dr. Cassell's quest for better treatment options led him to Focused Ultrasound, a revolutionary non-invasive technology with the potential to transform treatment for a wide range of medical disorders, from cancer to neurodegenerative disorders, neurodegenerative diseases like Alzheimer's and Parkinson's, to CCM. He's now spearheading the global adoption of the cutting-edge therapy through the Focused Ultrasound Foundation with the mission of redefining patient care and improving millions of lives worldwide. His dedication to advancing medical innovation is not just about a breakthrough technology. It's about the power of determination and the passion to help others, even in the face of personal challenges. Dr. Cassell is going to be speaking to us remotely. When he is done, there may be time for questions, but I would like you to let me ask questions, and that my questions may actually wind up filling the time because they'll be CCM specific, but we can have more opportunity for conversation later. So we are honored to have Dr. Cassell join us virtually today. Please welcome him.
Can you see me? Can you see the slides?
Yes, sir, we can.
Well, thank you for that most generous introduction. Let me frame this conversation by telling you that the way I got involved with focused ultrasound was related to CCM, because about 20 some years ago, I was casting about for a non-invasive or minimally invasive approach to treat a fairly large number of patients I had who had tumors that had maxed out on surgery and radiation and chemotherapy, or tumors that were in surgically inaccessible locations. And I was particularly intrigued with trying to find a solution to the patients who had brainstem CCMs. So that's where this all started. And then serendipitously, I came across focused ultrasound. So I'm going to talk to you about the focused ultrasound technology and about a little bit about the Focused Ultrasound Foundation. This is not centerline with what your interests are, but you'll see where the intersection does occur. So what if you could treat a patient like John McCain or Teddy Kennedy with a malignant brain tumor, glioblastoma, using sound instead of surgery and radiation and chemotherapy, and thereby extend their lives from 1 to perhaps 5 years or maybe even more? Or what if you could use sound to stop the progression or maybe even reverse the neurological deficits of Alzheimer's or Parkinson's disease? Or what if you could use sound to transform the treatment of metastatic cancer and convert it from a death sentence to a chronic manageable disorder? Well, it's a particular type of sound called focused ultrasound, which is the most powerful sound you will never hear, but a sound that someday could save your life. So focused ultrasound is an early stage, very rapidly evolving, revolutionary, disruptive, highly disruptive to physicians' referral patterns and practice patterns, totally non-invasive therapeutic technology that is an alternative or a complement to traditional surgery and radiation therapy. A whole new way of delivering drugs and other therapeutic agents more safely and effectively, and of enhancing the effectiveness of cancer immunotherapy, and thereby transforming the treatment of a whole spectrum of life-threatening or disabling medical disorders, and thereby serving as one of the rare technologies that fulfills the holy grail of not only improving outcome, but decreasing cost of care and increasing accessibility. So in its evolution, focused ultrasound is where MR scanning was 30 or 35 years ago. At that time, most people had not heard of MR scanning, but today, everyone has either had an MR scan or knows somebody who's had an MR scan. And by any and all measures, MR scanning has revolutionized diagnosis. And along the way, it created a new multi-billion-dollar diagnostic imaging industry. So focused ultrasound is where MR was 35 years ago. Most people have never heard of it. It's been called medicine's best kept secret, but it has the potential to revolutionize therapy to the same degree or more that MR revolutionized diagnosis. And it is creating a new multi-billion-dollar non-invasive therapy industry. And a lot of what you'll hear sounds like science fiction, like Star Trek, but it's not science fiction. It's very much rooted in reality. So here's some examples. This is a 64-year-old left-handed architect whose dominant hand, his left hand, is afflicted by essential tremor, a cousin of Parkinson's disease. And he's been unable to draw accurately for more than 10 years. So he was treated with focused ultrasound as an outpatient procedure, no drugs, no incisions, no holes in his head, wide awake. And at the end of the procedure, he could draw accurately for the first time in more than 10 years. And here he is 3 months later, showing that he's got no tremor whatsoever. Now, it doesn't take an enormous leap of faith to appreciate that if there's a technology that can use to treat something deep in the brain through the intact skull in an awake patient with a high degree of precision and accuracy, that same technology can be more readily used to treat things that are outside of the body, like tumors of the breast or tumors in more forgiving locations. This is a woman with a gigantic uterine fibroid. These are benign tumors of the wall of the uterus that are fairly common in young women. They almost never get to be this large. Clearly, this was interfering not only with this woman's family life, but with her work life. So she was offered hysterectomy, the standard of care, big operation, 5 to 7 days in the hospital, 4 to 6 weeks to recover, no more uterus, no more children. Instead, she chose focused ultrasound. It was an outpatient procedure. She went home the same day, was back to work in 2 days instead of 4 to 6 weeks. She still had her uterus. And here she is 9 months later, after the tumor, which had been destroyed by the ultrasound energy, had been absorbed by her body. No drugs, no incisions. This is an MR scan of a young woman with breast cancer. She was offered the standard of care, a surgical lumpectomy. She didn't want a scar and a dimple in her breast. She chose focused ultrasound. 62-year-old surgeon in Milan, Italy, with this large pancreatic cancer, which had spread throughout his body. He had failed 2 very aggressive courses of chemotherapy, and it was at the end of the line. He was given 3 months to live. And just for pain palliation, he was treated with focused ultrasound, and about 80% of the tumor was destroyed. Surprisingly, he didn't die in 3 months. And you can see in the 4th pane, almost 2 years later, the tumor's essentially gone, which was a surprise, but even more surprising, his systemic metastatic disease disappeared, which sends a signal that focused ultrasound has some immunomodulatory or immunotherapy effect. This is a young boy with a desmoid tumor. These are benign, but very aggressively growing tumors that are almost impossible to remove surgically because they're wrapped around the nerves and blood vessels and tendons and ligaments. And not infrequently, these kids end up with amputations to save their lives. So he was treated with focused ultrasound, and when and if the tumor comes back, he can be retreated. This 7-year-old girl in London was incapacitated with intractable abdominal pain and renal failure from this very large benign tumor filling her pelvis. She was operated upon, but the surgeons had to back out and abort the procedure because the tumor was too bloody. Because she was so desperately sick, on a purely experimental one-off basis, she was treated with focused ultrasound, and in a fairly lengthy procedure, about 60% of the tumor was destroyed. In 2 days, her pain improved. In 2 weeks, her renal function returned to normal. She returned 6 months later, and the majority of the residual tumor was treated. This is a young woman with metastatic colon cancer to the liver, treated with focused ultrasound instead of RF or cryoablation. An elderly man treated with focused ultrasound for this very enlarged prostate filled with cancer. A woman with varicose veins. This dog with an oral tumor was scheduled to have half of its mandible removed, which would have been a horribly disfiguring and incapacitating procedure, instead treated with focused ultrasound. And you can see 3 weeks later, the tumor's gone. So focused ultrasound is the integration of two innovative technologies. The focused ultrasound component, which is what provides the energy, which treats the tissue, and then medical imaging, either ultrasound or MR imaging, which is used to target and plan and guide and control the treatment. So the way focused ultrasound works is analogous to using a magnifying glass to focus beams of light on a point and burn a hole in a leaf. But with focused ultrasound, instead of an optical lens focusing multiple beams of light on a point, an acoustic lens is used to focus multiple beams of ultrasound energy on targets deep in the body with a high degree of precision and accuracy, sparing the adjacent tissue. Where each of the individual beams goes through the tissue, it has no effect. But at that focal point where all the beams converge, there's a number of really profound ways in which ultrasound interacts with tissue. Today, we understand more than 30 mechanisms of action of focused ultrasound as it interacts with tissue. About 10 years ago, we only understood 5. And the fact that there are so many different mechanisms of action, in contrast to radiation therapy, one mechanism of action, or a surgical robot, one mechanism of action, the fact that there's so many different mechanisms of action creates the opportunity to treat a wide variety of medical disorders, including destroying tissue by a number of mechanisms, one of which is just to heat that focal point and basically cook and destroy the tissue. And another is to use the mechanical energy of the ultrasound to create microshock waves and disrupt cell membranes without raising the temperature. And there are other ways of destroying tissue as well. Something that has tremendous potential and is already in clinical trials is using focused ultrasound to deliver drugs and other therapeutic agents precisely to the point in the body where they're needed in extremely high concentrations, much higher concentrations than can be achieved with the normal oral or intravenous routes of administration, and thereby improving the effectiveness of the drug, but also decreasing the systemic toxicity or side effects. And there's a number of ways of doing this. The easiest to understand is to use microbubbles. And microbubbles are hollow lipid spheres, approximately 1/10 of the diameter of a red blood cell. And these microbubbles can be filled up with drugs, chemotherapy agents for cancer, genes or growth factors for Alzheimer's or Parkinson's or ALS. And then millions and millions of these microbubbles loaded up with these drugs are injected intravenously. And the microbubbles with the drug inside circulate to every organ and every tissue. Wherever the blood goes, the microbubbles go. But the drug's inactive because it's trapped in the microbubble, except at the point where the ultrasound is focused. And at that point, and that point only, the microbubbles burst and release their pharmacological payload. Opening the blood-brain barrier. This has relevance to the CCM field. So the blood vessels in the brain are different than the blood vessels in the rest of the body in that they're coated inside with a single layer of highly specialized endothelial cells that exist to keep toxins and bacteria and viruses from getting into the brain. But unfortunately, they also keep important drugs for Alzheimer's or Parkinson's or brain tumors for getting into the brain. So focused ultrasound can be used to, in a very targeted manner, you can see that white rectangle in the second pane, in a very targeted or focused manner, reversibly, 6 to 24 hours, open the blood-brain barrier, allowing access of drugs that would otherwise be excluded. So the greatest breakthrough in cancer therapy in the last 30 years are these miraculous cancer immunotherapy drugs like Keytruda, which cured Jimmy Carter of his metastatic melanoma to liver, lung, and brain. The problem is that these drugs are only effective in 20 to 40% of patients, depending on the type of tumor. Focused ultrasound has the potential to increase that effectiveness, the response rate, from 20 to 40% to 60 or 80 or maybe even 90%. And the way it works is that as we sit here today, we have cancer cells circulating throughout our body. But our body's immune system generally recognizes those as troublemakers and kills them. But occasionally those tumors, cancer cells, aggregate and form tumors. And when they do that, they have a way of camouflaging themselves from the body's immune system. Focused ultrasound can strip away that camouflage, allow the body's immune system to recognize these tumor cells as troublemakers, and augment or enhance the effectiveness of these cancer immunotherapy drugs. So this is an MR scan of a patient with a metastatic brain tumor. And the tumor's identified. It's then targeted. The treatment is planned. And the magic is you can actually watch the effect of the treatment as it's being administered in real time by doing a scan every second or so through the target. Unlike radiation therapy, where the effect of radiation is invisible while it's being administered, and it takes weeks or months before the effect becomes apparent, with focused ultrasound, the effect is immediate and verifiable. And furthermore, patients can only take so much radiation without becoming sick. Focused ultrasound has no cumulative dose effect because it's just sound and pressure and sometimes temperature. Today, around the world, there are more than 180 clinical disorders in various stages of research and development and commercialization. A decade or so ago, there were only 3. That's how rapidly the field is growing. Now, you can see that most of these are in early stages of evolution because the field is still young and growing. And in fact, around the world, about 35 today have regulatory approval, 9 or 10 in the US. And that number is increasing and will increase rapidly in the near future. Now, when you see 180 indications, it sounds too good to be true. It sounds like snake oil, good for whatever ails you. But to be sure, focused ultrasound is not a panacea. It is not a silver bullet. It's not for every patient. It's not for every disorder. And a lot of work remains to be done to figure out where focused ultrasound provides unique value. So because of the potential impact of this technology on, without exaggeration, millions of patients, there's a lot of impetus to make it available in the shortest time possible, saving time, saving lives. The problem is that the evolution of any new, highly disruptive therapeutic technology, from laboratory research to widespread utilization, is a glacial process that often takes decades. The gamma knife, for instance, was invented in 1950, and it didn't become mainstream until 1995. And the reason is that the process or the path is very complicated and inefficient and requires a large number of really difficult steps that have to be accomplished by a bewildering array of organizations which comprise this ecosystem. And many of these organizations have different agendas and different timelines for decision making, and many have to interact with each other. And furthermore, there's a fairly daunting list of other impediments: lack of awareness amongst patients and their clinicians, long-term rigorous scientific evidence of safety and efficacy. Physicians as a segment of society are resistant to change, notoriously resistant to change. Fairly vicious turf battles develop between the medical specialists. Regulatory approvals take a long time. Reimbursement from commercial and government insurance agencies is an agonizingly slow process. And there's not enough young clinician champions to do these treatments. So when we got involved with this field 20 years ago or so, we cast about for a model or a playbook that we could follow that would shorten the time from laboratory research to widespread utilization. But we couldn't find one, so we were obliged to invent one. And that was the genesis of the Focused Ultrasound Foundation. So the Focused Ultrasound Foundation is a unique, multifunctional organization that performs the functions of all these other organizations, because at the time we got started, it was a greenfield. None of this existed. So we were founded in October 2006 as a 501c3 organization. The foundation operates very much as a venture-backed organization, but it absolutely is not venture-backed. It is a highly entrepreneurial, high-impact, high-performance, high-technology service organization. Several years ago, we were recognized by Charity Navigator as being one of the top 10 medical research organizations in America. And a number of years ago, the Batten School of Leadership and Public Policy and the Darden School of Business at UVA teamed up and wrote a case on the foundation as an exemplar of a social entrepreneurship and venture philanthropy organization, and that's taught twice a year at Batten. The center of gravity of the foundation is here in Charlottesville, Virginia, but we have very much of a global impact. We have sister foundations that we've created in London for the UK, in Utrecht for the EU, and in Hong Kong to serve Asia. The mission is very simple, just to accelerate the development and adoption of this technology. And the way we operate is on a quarterly basis because the field is evolving so rapidly. We look at the critical path from laboratory research to widespread utilization and identify the choke points or bottlenecks. And then we apply resources through a variety of programs, activities, and initiatives where we have adequate resources to do a good job in overcoming those barriers. The foundation has become the guiding light or the compass for the entire field. We provide capital. We spend a lot of time and money and energy breaking down silos of secrecy to foster collaboration. Research is the cornerstone of all of our programs. We organize, we conduct, and we fund research in concert with academic institutions, other disease-specific foundations, the manufacturers of the focused ultrasound devices, and other partners. Today, we have, to date, funded more than 450 projects. We currently have about 125 active, including about 40 clinical trials. We're interested ecumenically in all of those 180 indications, but where we concentrate our capital, our resources, both intellectual and financial, are on brain disorders and cancer immunotherapy. We convene the community by organizing workshops where we bring together for a day and a half or 2.5 days leading authorities from industry and academia and NIH and FDA, clinicians and scientists and engineers and physicists, and come up with a roadmap of technology development, preclinical laboratory studies, and clinical trials that are needed to create a new indication in the shortest possible time. Last week, we had a workshop on gene and cell therapy. This week, we had a workshop on epilepsy. The Foundation's website is widely recognized as the encyclopedia of focused ultrasound. It's the most comprehensive and up-to-date and trusted source of information. Our newsletter comes out 3 times per month. If you're not receiving it, you can go to the website and sign up. Very active on social media. A number of times, maybe 6, 8 times a year, we host webinars on topics that are related to focused ultrasound, like focused ultrasound and psychiatric disorders, or focused ultrasound and pancreatic cancer, blogs, podcasts, focus features, reports, and so on. We have a fellowship program where we bring to Charlottesville mid-career clinicians and scientists for a year or 2, and then they go back to their home institution where they've created the basis for long-term collaboration. We have a couple of internship programs. The first is the global program, where for the summer months, we twin about 20 of the leading authorities in focused ultrasound with young students for the summer months. And then here in Charlottesville, year-round, we have an internship program, mostly full-time during the summer, part-time during the school year. And a number of these students have chosen to take a gap year and work with us full-time. Awareness of the potential of focused ultrasound amongst all of the stakeholders is essential for advancing this field. So we engaged in a number of activities, including awareness events like this today. We have a very aggressive media placement program, print, broadcast, and digital. Several years ago, John Grisham, one of our directors, had the brilliant idea that he could use his storytelling ability and his brand to increase awareness amongst all of the stakeholders in one fell swoop. So he wrote this 44-page book about a patient with a glioblastoma and had it distributed for free by Amazon, and you can download it from the foundation's website. And more than 1 million of these books have been distributed, and we're brainstorming now about what the sequel will be. So in the last couple of years, the field of focused ultrasound has achieved a critical mass where we've reached the inflection point of this logarithmic or exponential adoption curve. And the dialogue has now shifted from if focused ultrasound will have a major role in the therapeutic armamentarium to when, from if to when. And of course, our role at the foundation is to make when now. But more interestingly, in the last 2 years, we've reached the transition point where we're moving from what has been historically a research and development environment to the beginning of a commercial patient treatment environment. Several months ago, we passed the milestone of 1 million patients having been treated around the world thus far, and we're on a trajectory to get to the next milestone, which will be at least 1 million per year, hopefully in 5 years. So in 2023, about 100,000 patients were treated in 1,000 commercial treatment sites around the world. 2024, it was about 150,000. Our goal is in 5 years to be treating more than 1 million patients in about 10,000 commercial treatment sites. So to execute the strategy, we've created an astonishingly strong team of A players. We built this team with the philosophy that A's attract A's and B's attract C's. And as a result of a rather draconian ongoing reconstructive pruning process, the foundation is populated entirely by A players. We have about 60 full-time and part-time people, most in Charlottesville, but a number around the world. 6 MDs, about 10 MBAs, 10 PhDs. The board of directors is not a typical philanthropic board. It is not a letterhead or a keyboard. It is truly a corporate governance board that represents the interests of all of the stakeholders. There's no social cachet associated with this board. There's no requirement or expectation to make a donation or to facilitate fundraising. We have another organization called the Council. Again, it's got a lot of very prominent individuals, but it is not a letterhead or a marquee organization. The purpose here is these individuals identify and make introductions to people of influence who need to hear about focused ultrasound to spread the word. They make introductions to individuals who can support the foundation philanthropically, and not infrequently they get involved with organizing, fundraising, and/or awareness building events. So the way we work is we take our donors' money and we use it, invest it in a variety of activities that overcome barriers and shift that Rogers adoption curve to the left, saving time, saving lives.
When I first heard I had Parkinson's, I was very surprised. I always thought of it being an older person's illness, and I've always seen people in wheelchairs, so I thought I was going to lose all my mobility. Basically anything that required movement, I couldn't do it. My leg would bounce uncontrollably. It would hyperextend and actually lock backwards. It was very, very painful. I couldn't walk, so I had to be taken in a wheelchair to the hospital. With each treatment, I could feel myself getting stronger and stronger. My symptoms were getting less and less, and my pain was getting less. Then the clinical trial director, she looked at me and she says, "Get up, you can walk." And I thought, I can walk. It was amazing. I got there in the wheelchair, unable to walk, and immediately following it, I walked to the room. It was a miracle. The focused ultrasound treatment has given me back my life. I've been able to go on walks. I've been able to run, being able to ride my bike again. It's a miracle.
So what the foundation does, this is an example. We took that essential tremor indication from an idea, it was purely an idea, to become a global standard of care. And to date, about 30,000 patients have been cured, and soon it will be 100,000 patients. So at the end of the day, what we do is take our donors' money and use it to create focused ultrasound, which produces miracles by transforming disease into health and happiness for millions of patients around the world. And I can say with a high degree of confidence that sooner or later, all of you who are listening to this, either you or a loved one or a friend, or maybe most importantly, your dog or cat, will develop a disorder which could be treated with focused ultrasound in the future. So the role of focused ultrasound in CCMs, first of all, opening the blood-brain barrier to facilitate delivery of drugs. But what we're in the process here at the Foundation of designing laboratory studies to use focused ultrasound to occlude or obliterate those small feeding arteries and draining veins, either with microbubble ablation, but more interesting, the thing that's got us excited is to use sonodynamic therapy, those photodynamic dyes, which can be activated by ultrasound, damage the endothelium, could produce endothelial proliferation and thrombosis, sort of a radiomimetic effect akin to what you would achieve with radiation and the gamma knife. And that, at the moment, is all I know.
Dr. Cassell, can you hear me now?
I can.
Oh, excellent, excellent. Thank you so much. That is just a tour de force of the potential, the history and potential of focused ultrasound for, as you mentioned, just a broad range of diseases. You know, as you heard, we are a community that's focused on treating CCM, and we're very early in the work, I think. And I'm wondering, I said I was going to ask the questions, but I think there's a few people that I would love to have just comment and get us up to date, because we have patients here, on what has been happening in the CCM field. In particular, Delaney Fisher is here. Delaney, are you here? Okay, so we are at this time trying to design a clinical trial that it involves not sonodynamic therapy in the way that you described, but just focused ultrasound with microbubbles opening the blood-brain barrier. Delaney, please come to the microphone. That you can go right over there to one of the ones on the stand. And I'm hoping that maybe we can, if Delaney explains it a little bit for our lay audience, we could get your take mostly on more practical advice for what we can do to make this move forward more quickly. Delaney?
Good morning, Dr. Cassell. So yes, my PhD with Dr. Richard Price focused on using focused ultrasound as a way to treat CCM. We looked at several different options initially, one of which was focused ultrasound blood-brain barrier opening. We also looked at sonodynamic therapy as an early option as well. Our idea initially with blood-brain barrier opening would be that we could increase delivery to these CCMs. And along the way, we basically discovered that with this blood-brain barrier opening approach and in our early safety studies, we could actually find that the lesions that were sonicating with focused ultrasound blood-brain barrier opening were stabilized over time in terms of their volume. as well as finding that the surrounding area of the brain that was treated with focused ultrasound blood-brain barrier opening were also forming a lower number of lesions over time. So of course, that's something that we're interested in moving forward, but there's also many other approaches that we could be looking at with focused ultrasound as well, as you mentioned.
So at this moment, we have developed a protocol, had it under review once with the foundation, your foundation, and it needed some pretty serious revisions. It is being, it would be a single center study at the University of Virginia, and we are now in preparation for a pre-IDE meeting. And so again, I'm just wondering if, and the manufacturer we're working with is Navifus instead of InsightTech, because InsightTech is not yet interested in us. So I'm hoping that you could give us some advice for how do we move this type of thing forward more quickly, and how is it that a patient organization can get the interest of a company like InsightTech to bring this technology more widely into clinical trials?
Well, the one important piece of advice is to engage the FDA and regulatory consultants to be sure that at the end of the study, you've got something that there's a pathway for regulatory approval, right? So that is key. In terms of getting the manufacturers interested, it's a little bit challenging because it's a rare disease and these companies have limited resources.
Any other suggestions for in lobbying these? So one of our thoughts was if we got together enough institutions to work on trials and had our own independent funding, that might, I don't know, somehow be a little carrot for a company, a larger company, to take an interest. Does that make any sense, or is that moving in the wrong direction?
Yeah, the fact of the matter is that you don't really need by the end of the first quarter of next year, InsightTech's low frequency system will be FDA approved. So it can be used off-label to treat patients in clinical trials with CCMs through the IDE process. So it's not going to be a barrier at the end of the first quarter next year. In terms of getting financial support from the companies for those trials, I think that is going to be very challenging. But, you know, we're interested in funding them. Other foundations are interested as well, as long as there's a clear path to regulatory approval.
Excellent, thank you. Are there any senior clinicians or researchers in the audience who would like to ask a question or make a comment? I'm thinking particularly of Dr. Awad. Dr. Cassell, these people don't know that I'm calling them out specifically. They had no advance warning.
No advance warning. Neil, it's a pleasure to see you. You're looking great. Dr. Cassell is a luminary for us vascular neurosurgeons who were trying to tackle problems early in our careers, when he was really a beacon of teaching and science, and his lab, initially at Iowa and later at Virginia, was a home for many, many people who made fundamental contributions. Great to see you, and thank you for sharing this. You know, we've been struggling with the Alliance to kind of calibrate here where is the truth as we move forward, trying on the one hand to grasp the opportunities that everybody really want, but on the other hand, not to fall in the common traps of biases and false hopes. So I think the process is working well. I think the initial ideas for a trial were probably not the best, and the scientific review process worked well in helping guide it. I think the next approaches of treating patients that need treatment rather than lesions that may not need treatment is probably more appropriate. And we shouldn't be afraid of the results. If this is going to be good, we will find it. If it's not going to be good, we will fine-tune it so we can find how best it'll be applied. I think we're in the middle of the rough and tumbles of how to best calibrate that and make sense of the results. A huge opportunity here, and that's kind of the perspective I share. Thank you.
Thank you. Dr. Cassell, any thoughts or comments?
No, I think one of the challenges in dealing with this disease is designing the clinical trial, because the natural history is so variable. I can remember a number of patients I had that had CCM. I took them to the operating room and did the MR scan in anticipation of the surgery, and the tumors had shrunk or disappeared. So, you have to factor that in to the design of the clinical trial.
Yeah, we're hoping to be able to make the right choices for our patients, and I think that was the critical thing and the change that was needed to the protocol.
Mm-hmm.
Okay. Are there any other researchers or clinical faculty, before I open to patients, any other researchers or clinical faculty who have a question? Yes, Favor.
Hi, thank you. Maybe, I don't know, a question, but I wonder in terms of dosage, do you think that it would be enough to give one strike to the patients, or is this something that in the clinical design, it should already be planned that maybe there will be multiple, interventions for each patient to actually see, a shrinkage or stabilization of these lesions? Thank you.
Well, with opening the blood-brain barrier to deliver drugs, I can imagine that could be multiple treatments depending on how the progression is. In terms of obliterating the vasculature, that's the small feeding arteries and draining veins, that is a one-time treatment.
Okay, thank you.
Clinicians, researchers, last call. Okay. Are there any patients who have brief questions that can be answered relatively quickly and are targeted?
It would seem that we use a single frequency for the tissue involved. Do you view in the future where we have multiple tissues, such as nanosomes on one case and the blood-brain barrier on the other, could a dual beam approach be to optimize those terms of reference?
The answer is, in theory, yes, but in practice, I don't think it's necessary at all.
Okay. Anyone else? Seema. Seema's running up to the mic now.
So I have to stand on my tiptoes. But for patients who have multiple lesions, do you see that this could obliterate multiple lesions at one time, or would it be, and how safe would you say that is?
My assessment is that it'll be very safe, and you can treat, just like treating multiple metastatic tumors, you could treat multiple cavernomas in one treatment, in one session.
Okay. Dave is coming up to the mic.
I have a brainstem cavernous malformation, so assuming a trial is available, would that be safe for brainstem to make my family feel better about it?
That's what the trial's going to be designed to treat.
Okay. And I also have, for the sequel to the book, patient with a cavernous malformation would be a great idea, I think.
We just
Yeah.
put a little B in John Grisham's ear about that one. Okay. Wilson from the University of Virginia is standing up to the mic. Can you introduce yourself so others know who you are?
Hey, Neil, how you doing? It's Wilson
Doing
Miller here.
Great.
Yeah. Just a quick thing. Maybe this is more directed at Delaney than anyone else, because I'd like to hear a response to it. But, I know that her study was performed in the context of injected microbubbles, and the idea was that, you would first make sure this was safe. And let me also preface by saying this was in mice, right? But what they discovered sort of unexpectedly was that you didn't necessarily have to load them with a drug in order to get some sort of a therapeutic effect. The other question that comes to mind is, do you even need the microbubbles? Can you just treat just naively, and of course that would make treatments much more simple than that. And my understanding is that we're not really sure at this point even what the mechanism was, that was causing this microbubble-assisted treatment we talk about it as opening the blood-brain barrier because that's what people have used this technique for before. But, as Dr. Awad has pointed out, the blood-brain barrier is already open in many of these lesions, so it's not kind of clear exactly what's going on. I didn't know if either Neil or Delaney had a comment on that aspect of it.
Okay. Dr. Cassell, can I let Delaney Fisher comment first, and then if you want to play cleanup after that?
Yes, so that's a great question. It's a question that I think we've all been wondering, especially in Dr. Price's lab after this study. So the graduate student that's kind of taken on this project in Dr. Price's lab, since I've graduated, is looking to answer this question. So they are basically designing studies where they'll be performing focused ultrasound sonication in the absence of these microbubbles to see if just the focused ultrasound energy alone is somehow helping to stabilize these lesions in terms of volume growth. This is something that we've seen in Alzheimer's disease, actually. It's been something new that researchers are starting to look at is initially we were using focused ultrasound blood-brain barrier opening in Alzheimer's disease patients, again, with the idea that you could potentially deliver drugs, but they're also seeing effects on potentially clearing out things like plaques and buildup in the Alzheimer's disease patients. And then we've kind of, this is mostly a group in Australia that's looking at if we just apply focused ultrasound alone, which I think was actually initially their control group, without the microbubbles, they're actually seeing improvements in those mice as well, especially in terms of memory. So this is something that obviously we need to look into. I think there's a lot of unknowns still with focused ultrasound. And again, there's lots of different forms of focused ultrasound, as Dr. Cassell was talking about today. So we're kind of looking at low intensity focused ultrasound, mostly in Dr. Price's lab, but we could also be looking at ablative heating or other approaches as well that could be more ablative to the CCM rather than mechanistically altering the environment around the CCM. Dr. Cassell, if you want to add anything, you're welcome to.
No, I think that's a good summary.
Would you know if there are other disorders, Dr. Cassell, that use only low-intensity focused ultrasound and that provides some therapeutic benefit?
Yeah, so as mentioned, focused ultrasound without opening the blood-brain barrier and without drug has been shown to improve cognition and increase clearance of beta amyloid and tau proteins in Alzheimer models. But there's a whole field of neuromodulation using focused ultrasound alone to treat everything from pain to addiction to movement disorders and so on.
Excellent, excellent. Okay. Allison, please come to the mic. And then I think we'll be wrapping up in just a minute or two.
I'm Allison, and I've spoken to my neurologist about this guided focused ultrasound. He said that he had a patient of his that had an increased prevalence of shaking and tremors. So I was wondering whether you could speak about both some of the adverse outcomes, but as well as some of the best outcomes. You give a couple of the adverse outcomes and maybe the top 3 or 4 best outcomes that you have seen so far. Thank you.
Okay, so Allison is asking about adverse outcomes that might have happened.
Well, it depends on what you're treating, but in treating Parkinson's and essential tremor, if you make the lesion off target, you develop difficulty with speech or vision or weakness, the complication rate of focused ultrasound treatment for these indications is diminishingly small. So that's not really a concern, and that's why it's FDA approved.
Okay. So we're getting better at this. All right. Anyone else? Okay.
Thank you. That was a great talk. I'm Shashank Shikhar. I'm a clinician, stroke neurologist. So my other hobby is neuromodulation using focused ultrasound, and I work in a neuromodulation lab as well. So beyond the therapeutic, what we are looking at is neuromodulation for motor recovery. My personal interest is vision recovery after stroke. We did a phase 1 study and looked at the safety, and we found that it depends on the dose, but we were within the FDA guideline, and we didn't have any serious adverse events. But there was one patient who had first-degree scalp burn, so that is something to watch for when you're applying.
Okay.
Thank you.
All right. Thank you. Dr. Cassell, do you have any closing words before we let you get back to your day?
No, but I just want to thank you for the opportunity to inform you about what's going on in the world of focused ultrasound, and hope everybody stays well. And if not, give us a call. We may be able to help.
Thank you. We are so appreciative of your time, and I cannot express how excited our community is about the potential for focused ultrasound. I think it's everyone in this room that is a patient or knows or loves a patient is looking forward to the day when it may be a treatment option for our folks. And we have you to thank for advancing this technology to the point where that could even be a sentence that I say out loud. So thank you. Thank you, and bye.
Bye.
We're going to break now, and could someone please tell me where the patients and clinicians are supposed to reassemble when they're done? Here comes Katie. She's hustling. Yes.